Thank you very much. I'm going to do the presentation in English, but I do have a reasonable understanding of French, so happy to take questions en français. I'm really pleased to be here. I have great admiration for what you are doing here in Montreal and in Quebec more generally in public health. Whenever I teach my population health intervention course as part of the PhD program at the University of Ottawa, I always start off by saying, look to Quebec for the innovators and where things are happening first in this country in public health. Any of my students will vouch for that. I'm not just making it up. I use seminars sometimes as an opportunity just for sort of diffusion, and at other times I use seminars as an opportunity to sort of try out some ideas and get some response and sort of some trial balloons. So that's what I've opted for today, because you are a very esteemed audience, and I'm really looking forward to a discussion and comments and questions, and perhaps we can continue that even beyond the seminar itself. So what I wanted to talk about today, and this is way too long a title, isn't it? Implementation Science and Population Health Intervention Research, and essentially to explore some of the intersections and how we might go forward. And I've prepared the seminar both from my dual perspectives as a scientific director within the Canadian Institutes of Health Research, but also as a research scientist who does work in this field. And these are some of the ideas that I've been sort of developing over time. So let me start with an observation and a premise that underlies my presentation. The observation, and this is probably more from my scientific director role, is that we're seeing a substantial and growing, but I would say a largely parallel investments in both population health intervention research and in implementation science. And my premise is that if we could examine and understand the intersections that exist between these two fields, it would help us advance both of the fields of research faster and hopefully would help us yield impact sooner. Here's just one of two slides that is about the observation. So this is just to give you a flavor of all of the work that is going on in the field of implementation science globally. I'm quite involved in the Global Alliance for Chronic Diseases, which you'll see there in the center of the chart. It's just one example where we're actually working with now 9 funding councils around the world to look at how do we develop an implementation science agenda for the area of chronic disease management and prevention. And then a more sort of localized view of what's happening around population health interventions. This is data from the Canadian Institutes of Health Research and shows investments between 2009 up to 2013-14. That's the most recent year for which we have data available that we can graph. Showing investigator-initiated, which is the darker green, and priority-driven funding in population health interventions. And then the lower graph is in implementation systems research in the population health area. So what you'll see is that there's been quite a pronounced increase. And you'll see that it's not only that we're getting, that we've got more investments in the priority-driven area, the strategic investments, but researchers are also being successful in the Open Operating Grant Program. So in exploring these intersections, I'm going to start with a few definitions and fundamentals. And then I want to talk about sort of 4 areas where I think these intersections are important to consider: the intervention design, outcomes, context, and scale up. And then I'm going to put forward at the end some ideas about a forward research agenda, and I'd love your comments on that. So some definitions, and that first one won't be news to any of you because Louise Potvin is based here and has been very active in the country, along with others, on population health intervention research. But that's the definition that appeared in the Canadian Journal of Public Health, looking at efforts to capture the value and differential effects of interventions, the processes by which they bring about change, and the context where they work best. So reference to context here. And this is the implementation science definition that we're using. There are others who have defined it as well, but often in the implementation science field, people do not have the equitable ways part of scale up. They just talk about scale up. But in some of the areas where we're working, that's something that we've actually included. And that's the working definition for funding opportunities, for example, within the Global Alliance for Chronic Disease. Here it's probably important to make a distinction between two different ways in which implementation science gets framed, both in Canada and around the world. So there's a version of implementation science which I would say is very synonymous with knowledge translation, and it's about how do we take the evidence that we've got and just put it into action. This is a sort of another domain of implementation science that I think has received a little less attention. And I'll show you in a few minutes where it fits into sort of a hierarchy of evidence. But it's really about a deeper understanding of the circumstances under which things work and the scalability of interventions, which I would argue we actually need to have in order to know how to move knowledge to action. Here, just some examples of how population-level health interventions are defined versus implementation science interventions. So the big differences are here a great concern about how do we get a redistribution of health risk and health disease that reflects our understanding of determinants of health. And often these are programs or policies rather than single discrete interventions. Sometimes in the health sector, but often involving other sectors, or they can be completely in other sectors and outside of the health sector. Whereas the implementation science interventions that we're seeing teams bring together in their funding requests are interventions that have the demonstrated effectiveness, but with good potential for scale up. They might be clinical or organizational or community health in their orientation or some combination thereof. And most frequently, I would say, in the health sector from what we're seeing across a range of funding initiatives. There's different fundamental preoccupations, I would argue, for population health interventions and implementation science. And these are just some examples. So this really is, again, about the shifting the health of populations and understanding the underlying reasons why risk and disease are distributed differently, and looking at who benefits when, what sectors should intervene. Actually, less attention here, I would argue, on the scale-up facet of our work. On implementation science, why is it that these interventions that we know to be effective, hi Christina, are not taking hold? And how is it that organizational and system barriers and facilitators affect intervention reach? And how can we optimally scale up effective interventions, and often in the health sector? So this is the hierarchy that I refer to, where I've placed implementation science as a contributor to knowledge translation. Some people would call this implementation science. I make a distinction there. And this is where I would place population health interventions. Now, if I was technically more adept, it would overlay these two. It would be more like a Venn diagram. That's what's intended in this diagram. So we've got population health interventions research, which I would argue are really essentially asking questions of effectiveness. And then we have some that are in this domain of implementation science. And this is just an attempt to try to look at how efficacy, effectiveness, and implementation research differ with respect to what we consider to be best-in-class designs, the emphasis in theorizing, and how we understand context. And I'll just point one thing out here, and I've got this in yellow, because pragmatic trials, some people would say, well, those really are about the implementation research, and that's where we're starting to look more at context. So I think there's pragmatic trials that are also part of what we see in the implementation science area, but often with other mixed methods. And I'm talking about mixed methods designs here. So it may be a pragmatic trial with case studies along with perhaps some qualitative research designs that are ethnographic, for instance, in their composition. So let me come now to those four areas where I wanted to point out some distinctions and in some cases commonalities: the intervention design, outcomes, context, and scale up. And I'll work through each of these. So intervention design, and I'll be interested in whether or not you agree with me on this one. So I have very sort of crudely classified interventions as those that are what I call research or researcher-driven intervention designs. So these are ones that are designed by the researcher. You know, you take your best know-how of previous studies, evidence of effectiveness, your best know-how about the underlying theories, your best program design model, and so on. And you design what you think is a world-class intervention that is likely to make a difference for your target group of interest. So that would be the sort of thing here. The context-driven natural experiments, and these are some of one of our funding opportunities, for example, is about this. As actually, we're interested in interventions that are naturally occurring. They're driven perhaps by, a policy window that's opened up, a readiness for government or organizations to move on a particular program, of a municipality to introduce the BICSI program, thinking about Lise Gauvin's work. But what drives them is the natural experiments, and they're not. What drives them is not the researcher. It's something within the context and within the system that creates these. And then I think we have another sort of hybrid model, which is what I've called here intervention layering, which is actually layering this onto this, and I'll say more about that in a second. I would argue that implementation science, at least right now, is largely in this area. It's largely looking at researcher-driven interventions, whereas population health interventions, I would say, has been more in this domain of natural experiments. And while that's an oversimplification, I can think of examples that don't fit with where I've put those classifications. I think overall, from what I'm seeing, that's sort of how it's laid out. And here are examples. So upper left actually is a picture from a study that's funded through the Global Alliance for Chronic Diseases, looking at how do you engage primary school children in China to reduce sodium in the diet, and how can they actually influence their parents to change their cooking practices and the use of soy sauce and so on. And they've got statistically significant results. Teach them how to nag. Yes, that's might be one way of describing the approach. But this was developed by the researchers. It's a primary school curriculum. They thought about context and what would work. They are concerned about scalability, but that's where it came from. As compared to something like the BICSI program that Lise Gauvin has studied extensively, work on urban renewal and that sort of thing, where it is a natural experiment that's taking place. The intervention layering is often where you have some sort of perhaps regulatory change. So we've got lots of examples of this in the field of tobacco, and researchers who are adding on something to that context, either in very purposeful ways or perhaps not so much, but counseling around tobacco cessation when you've got a change in tobacco regulations is opportune, and that's a layering. So if we think about the population health intervention side of the equation a little bit more fully, there's various examples, and I particularly like this one, of what are the kinds of options we have to take action on health inequities. So this is just one characterization, but this is really reflecting the kinds of interventions then that fit with that underlying understanding of determinants of health and the risk distribution of disease. And I think actually in both the implementation science area and the population health area, what we're starting to see is generally more attention to systems, and the systems that actually are the basis for and wrapped around the way services are provided. So we're sort of shifting from this area, a lot of interventions that have been tested without any attention to systems, health system or other, to those that are, we have better understanding of the constraints or supports of the system, to interventions that are actually trying to target the system itself, or interventions that are adapted to some system attributes, to interventions that involve system integration. So we're seeing a shift in our thinking. And I just came back from Australia a couple of weeks ago, and we held a workshop there involving a number of scientists in Australia talking about population health interventions. And one of the overarching themes that came out of that discussion was that they were all talking about the importance of moving towards understanding and locating your intervention within a system, whether that be a healthcare system or an agricultural system, or a police system, and so on, as sort of the next round of where we need to go. And we are starting to see, I think, some really interesting examples of typologies that are being suggested for looking at intervention options. So this is one from a systems perspective. This was just published during the summer, and builds on the work of Donella Meadows, who many of you will know was a systems scientist, who talked about the levels of change and what is the highest level of change that produces probably the most sustained, most impactful effect. And at her highest level was a change in paradigms. But if you look at these levels and maybe think about where would you insert your own research, I would say that many of us are working here, some of us working here, but very few at these levels. In fact, at the paradigm level, I think people often say, well, that's not even possible. How as a researcher would I do that? Maybe that's about advocacy, maybe it's not about research. But I would argue that we need to be thinking about what interventions are actually needed at all of these levels to move forward. So this is also something that I think is common to both population health interventions and implementation science. We're trying to look at how to drive more of the research questions up to the top here. So let me come to outcomes. And here I just wanted to make the distinction between outcomes where we indeed look at some stratification perhaps of the impact of an intervention by pick your social determinant, and that's actually very useful, and we're seeing lots of that happening in the implementation science area. But the structural determinants really are a big part of population health interventions. Although I think we're doing better on considering those and thinking about how to act on those in the design of our intervention, and we're doing much less better in terms of looking at our outcomes. Do we actually come back to look at whether or not we have shifted or shaped those structural determinants of health? And if you look at the outcomes people are using, a lot of them don't line up with this. They line up with other kinds of health indicators. Something I want to kind of pitch to you is in terms of outcome assessment, where do these two fields need to go in terms of using cohort data that's available and administrative data sets, whether those be administrative data sets in healthcare or in other sectors. And I think often the constraining factor is whether or not we think data is available or whether it really is available. Sometimes it's a perception gap as opposed to the reality for the settings and the communities that we're targeting for our interventions or the scale up of our interventions. We might be asking whether or not health inequities can be assessed from the data available, because probably many of those line up more with the social determinants and not so much the structural determinants. And then we would be asking ourselves who's actually represented in that data. And even if they're data of full populations, other than the census, they do not necessarily include everybody. And we want to know who is being excluded and why is that. So these, I think, are considerations as we move forward, and particularly as we move into the domain of scale-up science, of how do we use this kind of resource more fully, because the data that's available, I think, continues to constrain the kind of research that we're doing. There are various points of debate, and I don't have time to get into any of these in real depth, but I just wanted to throw them out there, and I'll talk a little bit about a couple of these around intervention research. And these debates are common for both implementation science and population health, but perhaps with somewhat different implications. So a common point of debate concerns the population heterogeneity of the mix of characteristics within your population, and some viewing that that just adds a lot of unnecessary complexity to your study and actually reduces the signal, it makes more problematic the signal-to-noise ratio. Lack of intervention fidelity reduces effectiveness. This is an ongoing key debate in our field. But interesting to think about what does that mean for a natural experiment. versus what does that mean for a researcher-designed intervention. Very different. And context, the view that context adds noise, and that's still the way we teach it in epidemiology. So this was a presentation I heard last week, and I had a chance to meet with Luke, which I thought was quite an interesting example. So they've taken the PRECIS tool, which was published in the CMAI back in 2009, which is designed around pragmatic trials and distinguishing features of pragmatic trials. And they used it, applied it to public health interventions, because for the most part, PRECIS has been used for other clinical interventions. And they took a whole bunch of case studies and systematic reviews that had been done that included both pragmatic and explanatory trials in the area of physical activity. And what they compared then were the odds ratio estimates that you actually got from the trials that were categorized as pragmatic versus explanatory. And what they found is that in 2/3 of the study, the odds ratio estimates were significantly less for pragmatic trials, which take into account context, compared to explanatory trials. So the conclusion they reached, and I think it's a valid conclusion, but I think there's some alternatives here, is that you get a voltage drop occurring when you run a pragmatic trial because of the heterogeneity, the context in which the trial is run, and so on. And I would suggest that, as part of understanding that, it is the heterogeneity of context and the participants that is reducing the effect when you're not adapting the intervention. So if you stick with the original intervention because fidelity is a concern, then you may end up with this apparent voltage drop. And this continues to plague us in public health when we're up against gold standard evidence for discrete interventions with high effect sizes, and we've got pragmatic trials showing relatively weak effect sizes. What is a decision maker going to choose in terms of what should be funded and what should not be funded? Chambers in Glasgow talk about this. They have another take on the voltage drop, and it's a very interesting paper to have a look at. They argue that we should be thinking about adaptation, and in a much bigger way than we think about it right now. And this is where I would argue that in implementation science, because they are largely researcher-driven interventions, it continues to be a raging debate, and how much do you adapt it before you kind of lose the core, the essence of what it is that works? Versus in population health, where we're looking at natural experiments, which are being adapted all the time. I mean, that's how programs run. That's how decision makers work. And you have to follow the trajectory, whatever that might be, of that natural experiment. We might not agree as scientists that the adaptations are optimal, but nevertheless, they are occurring. So Chambers in Glasgow suggests that we need to be thinking maybe more about a quality improvement type approach to adaptation, which means that we have to understand very quickly through cyclical iterative loops whether or not aspects of our intervention, researcher-driven interventions, are actually having the impact that we expect, good, bad, or otherwise, and then how might we adjust the intervention. So it becomes modified over time by the context. Davidoff talks specifically about this. He talks about improvement interventions in the field of quality improvement as being social treatments, and says, well, if you strictly adhere to your study protocol, then you actually negate the possibility of that adaptation. So from a funding point of view, we're kind of stuck in this model of don't improve as you go. We're stuck in the model of this is what you designed. It was designed to be the best possible. So suck it up if, it doesn't seem to be working. Don't adapt it. That messes up your protocol and the findings that you're going to get. And I think, though, that improvement science actually is ahead of us and ahead of implementation science in terms of looking at how to make adaptations at least within the complex adaptive system of the healthcare system. And maybe there's some lessons to be learned there in how we approach this. So context, that's a third area I want to explore with you. These are some reflections on context from some fairly large literature reviews that we've done. What we know is that it's deeply intimate. Those who understand context are the people who live it every day. So this is really part of what's behind the whole notion of patient-oriented research and patient engagement strategies. The patient knows their context. The community knows their context better than a researcher who is an outsider or a clinician who, too, is an outsider in a way, can ever know. And context is multi-level. It doesn't just exist at the level of your family. It exists in your workplace, and there's many facets to it. It's dynamic. It's ever-changing. So this makes that adaptation process particularly challenging. It's pervasive. So what you might deem to be the element of context of interest and define it that way does not necessarily mean that other elements of context are not operating. And some of those become evident, perhaps, as you roll out an intervention. And it's also contemporary, but it's historical. And if we think about residential schools and the impact on our Aboriginal peoples in this country, that's a really good example of a historical context that has absolutely contemporary implications for the work that we do. I'm going to skip that one. So we're starting to see now more coming out to guide us in how we think about context. I think this is pertinent both to implementation science and population health. These are some of the guidelines coming out of the MRC, looking at just how to think about context, and that it's there around every facet of the research endeavor. It affects our understanding of the problem. It should affect our intervention design. It should help to shape implementation. It interacts with interventions, and it moderates outcomes. So we have to take it into account from design right through analysis and interpretation. We also know, however, that we're not very good at describing that context. And there was a series of studies that came out, I think it was 2012, many of them coming up with the same sort of general finding that we, in our systematic reviews and in our primary studies, and systematic reviews can only be as rich as the primary studies, we're not very good at describing the health systems or political system factors that may be of real concern for policymakers who are trying to think, well, can this work in my setting with my realities? Even basic things like describing in the healthcare world whether or not populations have access to have universal access to healthcare, and what does that mean, is something that often is not described as context. So things that you and I would probably say would be highly pertinent are often missing in those primary study descriptions. We are working right now with the National Institutes of Health Research in the UK to actually develop a guidance document to provide further illustrations and guidelines and guidance rather than guidelines around how to address context within studies. So I think there's a lot of work happening right now about how to do this that has implications for both the population health and implementation science side of the equations. So scale up. These are some common elements of definitions. Nothing that will be a surprise to you there. Some of them do make reference to sustained improvements in coverage, not just to whether or not you achieve at some point improvements. A lot of them talk about innovation, because a lot of the work in Scale Up originates out of diffusion approaches, and a lot of it actually in the agricultural sector, where they were trying to diffuse particular practices among farmers, for example. And we also know that Scale Up requires some sort of underlying system, program delivery structure, in order to happen. In looking at the literature on this for a commission paper I did for the NIH, we came up with 3 classes of innovation that affect how we think about scale up. So one being discrete, a second one multi-component and multi-level, and the third one paradigmatic. So think back to what I talked about with Donella Meadows as sort of an illustration of that. And these are just examples of the classes of innovation. And they have different implications for how we approach scale up. Here, discrete vaccines, fluoride in drinking water are good examples of what we might be talking about, and often have a very specific dose and specific delivery parameters, and maybe less room for adaptation as well, compared to multi-component and multi-level interventions, as we've seen in areas of chronic disease management, for instance. Or paradigmatic, where we're trying to create a real shift in how we think about issues and how to address them. And we've all seen examples of paradigmatic changes in the US, a paradigmatic shift towards more of an expectation of universal coverage and access to universal health care for everybody. Paradigmatic shifts related to the way we think about chronic disease and its management. Paradigmatic shifts about, what hospitals and emergency rooms should be used for versus what they should not be used for, and what other services therefore are required to address gaps. But scale-up's kind of interesting, and this is where it intersects with sustainability, because if you think about fluoride in drinking water or vaccines, and when I was in Australia, there was lots and lots of talk about vaccines because they're having trouble hitting their sort of herd immunity level of vaccination, you can see a pullback, right? Something that you actually think, you've got the paradigmatic shift, and you've got a discrete intervention, and now we have fluoride being taken out of some municipal water supplies in Canada. And there's a number of slides I have here which I won't go into in depth, but just to give you a sense of factors that can limit scale up. And what I want you to be thinking about is, so how does this relate to population health interventions? And remember I said that I'm not sure we're thinking too much about scale up in population health intervention research compared to implementation science, where scale up is very out front. So you've got to understand the kinds of resources. It might be human resources, system absorption capacity, implications to scale something up. Another factor that's often limited scalability is political or policy naivete on the part of those who are trying to do the scale up, not understanding the actors involved, not continuing to engage stakeholders when government changes, not paying attention to scale up right from the get-go. This is something that's being addressed in implementation science. I don't think it's being addressed adequately in population health interventions that are natural experiments. Not paying attention to the demand side of scale up. A lot of it has been about, well, if we can just provide the supply side, everything will get fixed. But the demand side has to be pulled up as well. And overemphasis on either a vertical system or a horizontal spread of innovations, and you actually need a combination of the two, as we've learned through maternal and child health initiatives. And not attending to temporal dimensions of scale up, the fact that it has a life cycle, a trajectory, it changes over time, and there's differential rates of change in scale up at different levels of the system. So the policy may not be caught up yet, even though you're managing to do the scale up at the community level, and then without the policy support, it all diffuses. This is just an example speaking to the supply versus demand side. This is from skilled birth attendants in Asia. And the red are the populations most deprived versus the blue populations least deprived. And when you address supply bottlenecks, so you provide more skilled birth attendants, you see still a differential response, but there is some response. But this is where I'd like you to cast your eyes, because this is the demand side. And what we're seeing here is that actually, with respect to utilization, you don't have the same uptake when you provide the supply among the least deprived as you do among the those who are not so deprived. So this is speaking to the importance of taking time to think about that demand side of the bottlenecks if we're going to move forward on scale up. Lots of issues that need further development, but I'd like to hone in on these three just for a moment. And a question to you is, when do we consider a population health intervention to be scaled up? Doing a natural experiment, at what point is it scaled up? Is it scaled up already because it crosses your whole municipality? Or should it be scaled up provincially, nationally, globally? What does that look like? And I don't know that we're having enough of those conversations as we think about our population health research on interventions. What approaches to scale up optimally improve health equity? I don't think we know the answer to that question. I think we've got evidence of scale up that's not worked, and where people have not taken account of socio-structural determinants of health, and we've still got inequities at the end of the day. But what scale up approaches would actually work? Addressing the demand side is perhaps one way of helping to get at that, but I think there's other things that we need to consider. And this one I think is also very important and fits right within population health, but not so much on the implementation science side. And that is, what are the direct and indirect intersectoral costs of scale up? You're an economist, so I'm sure you've got views on that. But often we just take it from a perspective of health or a perspective of education. But there are cost implications and benefit implications that cross sectors, even if our intervention is in a single sector. So how do we start to look at that? So just a couple of examples of where we're actually trying to fuse these worlds of implementation science and population health. I would be remiss if I didn't tell you about a couple of funding calls. And these are just straight out of the funding opportunity, one of the earlier ones from GACD on hypertension, just to show you how we're trying to build in reference to some of these dimensions and encouraging researchers to think about them and asking our peer reviewers to evaluate on this basis as we try to bring together our thinking in implementation science and population health. So you can see that we're talking here about specific contextual influences that may be important, of policies as well that may be related to the intervention, and other kinds of networks or intergovernmental agreements and so on, both within and between countries that are challenges to the prevention, the program of interest and at scale up. There's a funding call coming out very shortly on chronic lung disease from CIHR for the next round of work in this area, and I'm happy to say a bit more about that. Another example of where we're trying to fuse this is Pathways to Health Equity for Aboriginal people. And there's a funding call right now for population health intervention research related to it. But again, you can see some of the references to context, references to systems, references to sociological conditions, so getting at the determinants of health, and references to scale up. So scale up of interventions is a very key part of what we're trying to do in Pathways, and to better understand it, and to understand how we do the scale up in ways that may reduce and address inequities. There is a lot of literature out there, and I just will highlight a couple of examples here talking about the way forward. A lot of it coming out of the implementation science area. I would say much less coming out of the population health intervention area, but I'm happy for you to disagree with that, because I'd love to see that literature if you think it exists. And talking about, how it is that we need to sort of move forward. I've highlighted a couple that I think are important. So this one by Riley speaks to that notion of how do we take the lessons learned of improvement science and build it into our work. But you'll see that many of these have an orientation towards researcher-designed interventions, because they come out of the field of implementation science, as opposed to what it is that we need to be doing vis-a-vis natural experiments. And there's even a third slide I'm not going to show you. That there's at least sort of 14 key articles we pulled out that talk about what it is that we need to do. I think this one actually can apply to both implementation science and population health. We need some common approaches that allow us to capture what the scalability involved, how we knew whether or not it worked, what processes were used, and what outcomes we might expect. So let me leave you with my top picks about the way forward, thinking about these intersections. So one is that I think we've got to make the structural determinants explicit in both population health and implementation science research. And that means thinking about them in terms of identifying intervention options and justifying them, in terms of describing contextual influences, and in terms of the outcomes that we come up with. And I think we're doing a little bit better on the population health side around the intervention options. I don't think we're doing so well yet on the contextual influences and the measuring outcomes. The second top pick I would have is that I think we have to start comparing the population health impact and the scale-up potential of natural experiments versus interventions designed by researchers. They tend never to be put in the same, lumped together in systematic reviews because the questions are often fundamentally different. And I'm not aware of much in the way of head-to-head comparisons that have happened here. And I think we have to start teasing this apart to understand, not just for the purposes of understanding how these two approaches can help the field move forward, but to really help us with figuring out the recommendations and so on that we might make sense of. And if we're seeing different kinds of effects from natural experiments, what's going on there compared to interventions designed by researchers? I think we've got to really think about how to optimize complementary work through funding opportunities and the peer review evaluation criteria. We think we've made some headway on that with respect to the work that we're doing in the Global Alliance for Chronic Diseases and Pathways, for example, but I think we have some way to go. And then related to that at the level of pulling together a research team is how do we get the team composition for the best-in-class research designs that bridge these two fields of science. And I'm not sure we're doing that very well yet, but maybe it's just too early. And finally, this is always a huge driver in how articles get written and what actually gets out there. And we've got lots of knowledge synthesis methods that are being used. But I don't think we have methods that are very good yet at looking at implementation, context, interaction. Some of that's a problem with the primary studies, so we have to do it in the primary work before we can synthesize it. I don't think we are very good at characterizing and capturing population health outcome assessment, especially on the implementation science side. And I think we need methods that help us look at the equity impact of scaling up interventions across sectors. And I think population health intervention specialists, if I can call them that, have a particularly important role to play there. So that's a lot to digest, but I wanted to leave a bit of time for discussion. And thank you very much.